I know I was kind of having a little trouble hearing this morning, so I want to make sure everyone can hear me. Thumbs up. Cool. All right. Hope you enjoyed your nice little break. As Jim said, my name is Alia Al-Tayyib, and I am based at Denver Public Health. I'm also an associate professor in the Department of Epidemiology at the Colorado School of Public Health. I actually did my training just down the street in Chapel Hill. So it's nice to be back in North Carolina, although it feels a little weird being in Durham. The wrong shade of blue. So this morning, so this morning I'm going to be talking to you about social networks of youth and young adults who misuse prescription opioids and heroin. And we're going to shift gears a little from some of the talks that we heard earlier this morning. So I'm really going to talk about kind of primary data collection for networks. And spoiler alert, it's hard. So I'm sure you're aware that this country is in the middle of an opioid crisis. So this is just this slide from the Center for Disease Control and Prevention that sort of shows the opioid epidemic in the three waves that we've been experiencing. So the first wave really started back in 1999, where we started to see a rise in overdose deaths that were related to prescription opioids. And then around 2010, we started to see this dramatic increase in overdose deaths that were really more attributed to heroin. And I'm sure if you've heard anything in the news, there's all the reporting about kind of the shift in the epidemic in terms of prescription opioids becoming harder to access. And so you saw kind of a transition to people getting pushed to heroin, which was readily available, a lot cheaper. And so we saw this concurrent kind of rise in overdose deaths related to that shift. And then kind of early in 2013 and on, we've seen a huge spike in overdose deaths that are really related to fentanyl, which is a much more potent opioid. And it kind of hit the East Coast hard to begin with, but it's definitely spreading to the West Coast. We're starting to see it in Washington State, and fentanyl's kind of coming in on the West Coast as well. So I'm going to give you some numbers that kind of give background related to prescription opioids when we were conceptualizing this study. So looking at kind of the misuse of prescription opioids, it's pretty prevalent among youth. So kids between the ages of 12 to 17 report anywhere between 4 to 11% of kids in that age group report a past use of non-medical prescription opioids in the past year, which is pretty high considering that young age group. Again, these numbers are a little dated, but when we were conceptualizing the study at the time, about 44 people a day were dying of an overdose that was a result of prescription opioids. And I'm blanking on the author's name, but there was an MMWR that came out in 2012 where basically they kind of calculated the number of other adverse events for each overdose. So for every unintentional overdose that was related to an opioid pain reliever, there were 9 people who were admitted to substance abuse treatment, which is obviously an outcome that we would like to see more of. There were 35 people admitted to the emergency department. Those were likely due to non-fatal overdoses. 161 people would report drug abuse or dependence. 461 would report the non-medical use of prescription opioids. And then, again, to sort of get at this shift to people shifting to heroin, we don't really know kind of how many people or what the rate of transition to injection drug use is. So my background is as an infectious disease epidemiologist, and so that is sort of an area of interest to me is the risk. Obviously, with injection drug use, there's a lot of adverse outcomes, but from an infectious disease epidemiologist perspective, my interest is really as it relates to the risk for acquiring either HIV or hepatitis C. So in terms of the probability of infection for HIV, the estimated per act probability of acquiring HIV is 61 per 10,000 exposures to a needle a needle that is infected. And HCV is actually a much hardier virus, so it can be transmitted via not just needles, but the equipment that's used to prepare drugs. So cottons, cookers, water. It can actually survive in a bottle of water for 3 weeks. Interesting factoid. And then we also know that social networks really can influence the pathways into injecting drugs, and that youth are particularly vulnerable to the influence of the social networks. So this, the study that I'm going to share with you today was done in the context of a K award. I'm assuming that several of you in the audience are either postdocs or early professors and might be considering a K award. Just a word to the wise, part of the reason that I chose this age group was because there wasn't much in the literature about this age group related to this topic, and now I know why. Really hard. So as I'm sure you are already familiar, or if you are not, you will be very familiar by the end of this week, but social network analysis is used to model human relations. It actually allows researchers to kind of get a better idea of sort of what's going on. So you're not just looking at individual level behavior, you're looking at sort of how a network could influence that behavior. And when you're looking at social networks, you're looking at attributes that can either be related to the structure of the network. So if you're talking about the homogeneity or the strength of the ties or how many people are in each component, you can look at social network from that perspective. You can also look at social networks from sort of the exposure. So, what are the risk behaviors look like for the peers? Again, from an infectious disease perspective, where are the people who are infected with HIV or Hep C located in the network? And then you can use network measures to examine the relationships between those members and how those relationships influence behavior. And so, again, part of the allure of social network analysis is that it can yield much more meaningful measures of sort of social integration and that influence on behavior. The con side is that the collection of network data can be very challenging. So this is just an example of a network. It's actually from Eric Rice, who is at the University of Southern California, and he collected data from a sample of youth who were experiencing homelessness, and he would recruit them at a homeless shelter. So they were somewhat bound by kind of the venue that he was recruiting them in. But kind of similar to the previous speaker, you see a lot of isolates in the network. So even though all these youth are visiting the same venue in a network, you can kind of see that some people are not connected. So I don't know how many of you are familiar with respondent-driven sampling, but again, by the end of the week, you should be a little more familiar. But it's basically a sampling methodology that relies on using peers to access hard-to-reach populations. So what you do is you identify an initial seed participant, you recruit them, and then you get them to recruit people that they know, because obviously the theory is they're connected and they know people in their networks better than researchers would. And so RDS, it employs a dual incentive structure. So you give the participant an incentive when they come in, and then for each person that they refer that is eligible, they get an additional incentive. So one of the strengths of RDS is that because there's this coupon structure that people need to use to refer each other, you have documented ties between the people. So this is just an example of an RDS recruitment chain. Across the top are the initial seed participants, and you can kind of see that sometimes you get a seed who is not productive at all. Sometimes you get a seed who might just recruit one other person, and then the hope is that you get seeds that are particularly productive. So again, this was in the context of a K award, and so I had to think of a creative idea to sell. And I also had to, in a K award, you have to have sort of career development goals. And so social network analysis was going to be the thing that I learned how to do. I'm still working on that. So this is just kind of a depiction of kind of, again, sort of those documented behavioral ties and recruitment chains that you get from a typical RDS study. And then this is kind of a schematic of what you might get from a social network study. And so we thought, like, hey, why don't we combine the two methods so that we can use RDS to get these hard-to-reach populations, but then also for the people who actually come in to participate in this study, we would ask them about their networks. So I'm going to talk to you this morning about the social networks of abused prescription pills in youth study, or SNAPPY. So if nothing else, I got a pretty jazzy study title out of all of this. We tried to be a little subtle. The blue was kind of supposed to look like a oxycodone pill. So to participate in the study, people needed to be between the ages of 15 and 24. If they were under 18, they needed to be able to consent for themselves. And that meant that they had to either be living separate or apart from a legal guardian and managing their own financial affairs, meaning basically they were living on the street. They had to be seeking an exam or treatment for sexually transmitted infections or HIV, or be seeking medical care or treatment for addiction or drug use. We defined currently misusing prescription opioids as happening at least once in the past 3 months. So we wanted people who are either currently misusing prescription opioids or people who are using heroin after a period of misusing prescription opioids. And so we didn't use any sort of clinical definition of opioid use disorder. We just asked them if they'd been hooked on opioids before they started using heroin. And obviously they had to be willing to provide information about their social network. So the overall goal of SNAPPY was really to try and understand the transition from prescription opioid misuse to injection drug use from a social network perspective. In terms of the procedures, they obviously had to be able to consent to participate in the research. Because of the nature of the data that we were collecting from people, we had a certificate of confidentiality from NIH, and we had a fairly extensive consent process that they went through. They completed an interviewer-administered behavioral survey that asked a lot about their kind of initiation into prescription opioids, and then if they had transitioned sort of, the age at first heroin use, frequency, and similar questions as they related to injection drug use. They completed a social network interview, and we also had them draw out sociograms. So basically when we did the social network interview, we had a magnetic board where the research assistant would write the names of the network members on as they were enumerated. And then at the end, we asked them to group people in 3 ways. So we asked them to group them by sort of who hung out together. We asked them to group them by who, if they knew, used prescription opioids together, and then who injected together. And so then we took pictures of those sociograms and tried to sort of create a big network. We also did HIV and hepatitis C testing and counseling. Again, because we were using RDS to recruit people, people got up to 5 coupons to recruit people from their network. They received $70 for their participation. And then for the referral incentives, when we first started the study, we were giving them $20 for each referral. By the end of the study, they were getting $40 for the first referral, $50 for the second, and $60 for the third, fourth, and fifth, which is a lot of money. So you would think people would participate, but apparently not. And for people who weren't eligible, we gave them $10 for their time for screening. So in full disclosure, I was actually a fellow in 2017. So had I presented this data in 2018, it wouldn't seem so dated. But I wasn't able to make it back last year, and Jim kindly allowed me to come back this year. So the data is a little old. And I think I also had PTSD like right afterwards. So, but anyway, we collected data between October 1st of 2015 and April 25th of 2017. We screened a total of 217 people. Of the 136 people who who weren't selected to participate, 11% weren't selected due to age. The majority, or 67%, weren't selected because the person didn't report misuse of a prescription opioid or heroin use. And then 10% were unresponsive despite multiple contact attempts. So as I've alluded to, it was very challenging recruiting this particular study sample, particularly because a lot of network studies, like AdHealth and other studies happen within, you sort of have a roster of everyone that's in the network. So it's a very bound network. This population, there's not a registry for kids who are messing around with drugs, although I'm sure every parent would love it if there was. So again, which is why we thought RDS would be an effective way to reach this population, because in sort of older users, in older populations of people who inject drugs, RDS tends to be very effective. I mean, you can get a sample of 500 from like 4 seeds. But I'll still share some data. So as you can see, so this kind of just shows like month by month our study recruitment progress. So when we started out at a pretty good clip. And I think maybe we just kind of sort of got all the participants that we were going to get. It was kind of the low-hanging fruit. And again, despite sort of increasing incentive throughout the study, we just had sort of plateaued. But at the end of the day, we were able to recruit 81 participants. 54 of those were seeds, and 27 were referrals, which again isn't really how RDS is supposed to work. RDS, theoretically, you should have a kind of small number of seeds that sort of generate your bigger network. So in terms of the sample that we ended up analyzing, despite how hard they were to recruit, we ended up dropping one participant from the sample because they were outside of the age range, even though they had completed the survey and referred people. But those 80 participants provided information on 537 alter namings. The sample of participants was predominantly male, predominantly white, and about 60% of them reported experiencing homelessness in the past 12 months. The mean age of the sample was 21.4. In terms of kind of the distribution of their drug use, 14% reported that they only use prescription opioids. 6% reported that they had used heroin but had only smoked it. And the bulk of the sample, or 80%, had already transitioned to injection drug use. Interestingly, 53% described growing up as middle or upper class, and 20% identified as LGBTQ. So if you remember the slide that had the RDS, social network, and then the combined, so this is kind of walking through how we created that combined socio-matrix. And when I say we, I mean Steve Muth. For those of you who are familiar with HIV and social networks, Steve Muth is kind of the go-to networks guy. He is based in Colorado Springs and was kind of instrumental in collecting the data for Project 90, which is it was like one of the first HIV outbreaks that happened in the early 90s. It was a pretty extensive network data set that has been used. I think people use it a lot for sort of simulations and that kind of stuff. So again, Steve did this. So we had 537 named alters, as I've already mentioned. Of those 537 named alters, 34 were names that represented 24 different people. So, 2 people could have named the same person. Of the remaining 503 alter names that were collected, 26 people were actually, again, sort of like those, someone that like person A named and person B named that we were able to cross-link by a matching process. So if we had gone about analyzing this data as 80 separate egocentric networks, it would have appeared that there were 617 people. So again, without going through this deduplication process, it would have looked like we had 617 people, 80 of those being the egos and 537 of those being the alters that were named, we were able to kind of do this matching process where we deduplicated everything. So we ended up with, again, the 80 ego participants, and then we had 589 unique non-respondent alters. And when I show you the sort of depiction of the network, it'll be a little clearer what I mean. And the way that we sort of did the matching was, so say person A said that they knew John B, and person B said they knew Johnny B, and John B and Johnny B were roughly the same age, and they were both male, and they both were reported to hang out at the same homeless camp, then we could say, like, we can make a reasonable assumption that that's the same person that both of those people are talking about. Does that make sense? So just comparing kind of what the demographics look like between the egos and the alters. Again, this was kind of a function of the study design because of the age limitation that we had. But the mean age for the egos was about 21.4. But for the alters, it was 27.2. One of the things that was definitely obvious kind of midway through the study was that younger people tended to be, especially those who are experiencing homelessness, tended to be networked with older people. And part of the reason for that is just kind of a sort of survival technique. And so, you would ask people to define the relationship of the people they were naming in their networks, and they would say things like, well, that's my street dad, or that's my street mom. And so that was something that I just didn't really think about going into the study, that maybe in order to reach younger people, we would actually need to sort of start with older people because they're the ones who might be networked with them. In terms of the gender distribution, again, the egos were predominantly male. In terms of people that they named in their networks, about 67% of the alters were male and 33% were female. The age or the race ethnicity distribution was fairly similar between the egos and the alters. In terms of people reporting experiencing homelessness, of the people that we actually interacted with, 60% of those people reported experiencing homelessness, compared to 37% of the people that they reported or that they named. In terms of injection, again, the sample that we ended up with was a sample that had kind of predominantly already transitioned to injection drug use. We asked them of the people that they named in their network who had injected, and so about 46% of the alters were reported to have injected. And then we did not have any cases of HIV, but given the very young age of the sample, there were 28% of the sample was already positive for hepatitis C. And given that, they report that they've injected with, or that 46% of the people that they named had injected, this is kind of a ripe population to intervene with. In terms of the network analysis, the prompt that we asked to construct the social network was, think about people you have contact with who have been involved in your life in a significant way during the past month. And then we also asked a location prompt to try to create, again, sort of this robust sociomatrix. So we asked people, of the people that they named, where does that person hang out? And then the focus of the analysis, again, was really trying to understand this transition from prescription opioid misuse to injection drug use. And so we examined K-plexes, which I assume that you will also learn about if you haven't already. But K-plexes are basically subgroups where you're trying to determine how many other nodes a node is connected to. And so you can rank the K-plexes based on how connected they are. So for our analysis, we used a K-plex of size 2. So this is just an example of kind of that K-plex, a K-plex of 2 of size 5. So there are 5 nodes in the K-plex, and we're looking at just the 2 connections. So the kind of bigger and more numerous K-plexes are ranked higher. So basically, you're trying to determine kind of more dense areas of the network. We visualize this with Payek, and then the ego sizes are kind of proportional to the K-plex. So this is the end result of all that work. There's a lot going on, so I'll just kind of walk you through it. And I know probably in the back it's kind of hard to see, but basically the red egos are like the little people nodes. The ones that are red are participants who had already transitioned to injection drug use. The nodes that are blue are people who reported just using heroin but not having injected. And the nodes that are green are people who just reported misusing prescription opioids. And then those colors are the same for the people that they named in their network. And so you can see that we kind of ended up with and this was, again, because RDS didn't really work the way we thought it was going to, a lot of these connections were made. We also use the location data that people provided. So if, say, person A said they hung out at a particular McDonald's and person B said that they hung out at that same McDonald's, then we sort of link them to that location. And so those are depicted by the kind of house shapes. But basically, you can see that the kind of bulk of the network and where it's the densest, those nodes, and again, I think this is probably a reflection too of the sample that we ended up with, but those are people who had sort of already transitioned to injection drug use versus, you can kind of see out there on the left, those 2 kind of clusters where the node is blue, indicating that they hadn't transitioned. Those are sort of less dense, less connected networks. So just in terms of kind of challenges and sort of some of the implications from our findings, as I mentioned, it was very difficult to recruit this population. That said, I think we ended up with a lot of very rich data that I have yet to begin to scratch the surface of. Again, I think RDS, for whatever reason, just with younger people who inject drugs, didn't seem to be very efficient in recruiting them. That could be because younger people who are sort of earlier in their injection career, that's not the right word, experience just might not be as kind of, they might not identify as that being an activity that they really engage in versus, someone who's been injecting for 15 years, um, maybe has come to accept that. So again, kind of RDS not working for younger users, we just might need to find another way to access them. And as I had mentioned, kind of the network finding was really that, and I don't know if this is truly a reflection of the network or just the sample that we ended up with, but the people who had transitioned to injection drug use seemed to be in much denser regions of the network. And so I think, obviously we need sort of more prevention efforts that are really targeted towards youth, and whether that's identifying them once they're misusing prescription opioids before they've transitioned to injection drug use, or just identifying, trying to identify risk factors for initiating drug use in the first place is something that we need. So obviously I did not do this on my own, so thank you very much to the Social Networks and Health Fellowship and to Jim for generously allowing me to come back and present. I will sit through a couple of days of the workshop because I need to hear this information again. It's very dense. As I said, this was part of a K award from the National Institute of Drug Abuse, and so I wouldn't have been able to do this without my mentors. Steve Muth really was the whiz behind all the network creation. Paula Riggs was my main mentor at the University of Colorado. Eric Rice is at the University of Southern California. Carl Atkin at Hopkins. Sam Friedman at NDRI. Jesse Carlson was my research assistant, without whom I would not have been able to collect any of this data, and obviously the participants for providing the data. So, thank you.
Alia, 4 stories that need to be recounted.
That's not to discourage you. It was very much a learning experience. So you should definitely get in there and get your hands dirty.
Hi, first of all, very interesting topic. I have actually 2 questions, and I may have missed it. When you said the 12 unique persons, what did you mean about the unique persons?
So because, you could have, because we enumerated people's networks, we kind of matched to make the connections. So again, because RDS usually would be the process where you would say like, okay, like this person knows this person knows this person because they referred each other. And you could know that this person is a unique person because of their study ID. So because we also collected network data that was reported to us, we wanted to make sure that if this participant named one person and this participant named another person that were probably the same person, we wanted to make sure that we captured that. Because the other thing that happened was just like even though we were collecting first and last names, a lot of people used nicknames.
Oh, like Johnny.
Yeah, or Skinny B. I mean, there were all kinds of descriptions that I was like, oh wow, that's what you call that person? Okay. So yeah, so just making sure that we were cleaning the data in a way that we can say like, okay, that is the same person, and we can link them.
Okay. And then my second question is, because I'm doing a study with a very unique population, particularly athletes, and they're very hard to contact in so many ways. What other suggestions do you have in terms of sampling, like for the populations that are hard to reach?
Well, we think athletes, I mean, if you're like going after a certain team, there's probably a roster of that team.
Right. Yeah, there is, but in terms of just limited time with them, and also the name generator referral sometimes can be a little tough, especially working with the
Mhm.
just accessing the names for, am I really going to say my teammate's name or refer to a particular coach's name? So were there any, I guess there was maybe any limitations within that aspect, but I just had the same issues in terms of population recruitment.
Yeah, I mean, one of the things that we did to try to make it a little easier for people to refer people for RDS was instead of actually making them take like a physical paper coupon and hand it to a person, like they could text that person, and so we had like a ready to go script that if they wanted to refer people that way, we would just send it right to them, and like we collected the network information on paper, and so like we would kind of scan and be like, well, why don't you send, do you want to send it to Johnny B, who looks like he's pretty connected and might be a good participant. So one of the things that we ran into was people seemed really enthusiastic about referring people when we were with them, but as soon as they walked out of the door,
Thanks.
mm-hmm.
Comments? We are going to have a session on generalized data collection tomorrow, as well as a dedicated session on RDS. Kathy Harris will be talking during our lunch talk today about some of the IRB issues.